Welcome to the deep dive. If you've ever looked at a chart of antiarrhythmic drugs and just felt completely overwhelmed, you are definitely not alone. This topic is notoriously dense.
It is. It's so challenging because the classes, class 1, 2, 3, 4, they feel completely arbitrary. And if you just try to memorize them, it's an exercise in frustration. It feels like you're trying to decipher, I don't know, ancient hieroglyphs.
But we have a mission for this deep dive. We are going to give you a logical map. The key is to stop thinking of them as lists and start seeing them as, well, really specific tools.
Exactly. And you can't use the tools until you know the anatomy. We have to understand the heart's electrical language first, the action potential, to really get how these drugs intentionally mess with it.
And that starts with a really fundamental point you made earlier. The heart has two totally different types of tissue.
It does. They operate using completely different ion channels. They have unique behaviors, and our whole strategy depends on which one we decide to target.
Okay, let's unpack that language. Let's start with the heart's own rhythm generators.
We call these the pacemaker cells. They're mainly in the SA node and the AV node, and their defining feature is something called automaticity.
Meaning they just go on their own.
They go on their own. They don't need an external signal. They depolarize all by themselves. They are the engines of the whole system.
And that AV node, that's the crucial choke point, right? It's the only electrical path from the atria down to the ventricles.
It's a hugely strategic choke point, absolutely. And because these pacemaker tissues rely so heavily on calcium, we call them slow-action potential tissue. Their resting voltage never really rests. It just sort of drifts upward.
That's low drift. That's key, isn't it?
Yeah.
It dictates the heart rate. So how does that spontaneous depolarization actually happen?
So that's phase 4. It's this slow upward ramp, and it's caused by these channels that electrophysiologists brilliantly named the funny sodium channels. Yeah, they're funny because they open when the cell gets negative, which is the opposite of most channels. So a little sodium trickles in, warms up the cell, and then some T-type calcium channels help it get the rest of the way to the threshold.
So the funny current gets us to the starting line. What actually powers the main signal, the upstroke?
Once you cross that threshold, you hit phase 0. And that upward spike is driven entirely by L-type calcium channels flooding calcium into the cell. Then for phase 3, potassium channels open up, potassium rushes out, and the voltage drops back down.
Got it. So that's the rhythm setter. Slow, automatic, driven by calcium in these funny sodium channels. Now for the other 99% of the heart.
The atrial and ventricular myocytes, these are the non-pacemaker cells.
They're just waiting for the signal.
Exactly. They don't generate their own spark. They just pass it along through connections called gap junctions. And these are the fast action potential tissues.
And the graph looks completely different. It's that speed of depolarization. Where does that come from?
That near vertical spike phase 0 in this tissue is all about voltage-gated sodium channels. They open instantly, flood the cell with positive sodium, and boom, you get that incredibly rapid upstroke. This is the critical target for our class I drugs.
And after that spike, you get that long, flat plateau. Phase 2. What's the point of that?
The genius of the plateau is balance. The cell stays positive because the positive calcium coming in through L-type channels is perfectly matched by the positive potassium going out. It's an equilibrium.
And that keeps the tissue refractory, right? It protects it.
It protects it against premature signals. Then in phase 3, the calcium channels close, potassium wins, and the voltage plummets back down to its resting state, phase 4, where it just waits for the next signal.
Okay, so we have the language. We're treating tachyarrhythmias, fast heart rates caused by hyperactive engines, random sparks, or electrical short circuits.
Right. And the strategy is either, do we slow down the AV node, or do we try to fix the problem in the muscle itself? Let's start with slowing down the node. Strategy 1, rate control.
So the goal here isn't to fix, say, atrial fibrillation. It's just to protect the ventricles from all that chaos coming from the atria.
We're just putting in a speed bump, a big one. We're targeting the slow-action potential tissue of the AV node.
Which means we're going after those L-type calcium channels that drive its firing rate.
Exactly. Which brings us to our first group, class 2, beta blockers. Metoprolol, the OLs.
How do they do it?
They're indirect. They block beta-1 receptors, which cuts off the go signal that normally encourages those calcium channels. So by reducing their phosphorylation, you slow them down.
So you get a less steep slope for phase 4 and phase 0, slower heart rate.
Slower conduction, slower heart rate, exactly.
And you have class 4, calcium channel blockers. Verapamil, diltiazem. This is the direct approach.
Yeah, no messing around. They just physically block the L-type calcium channels. The effect is similar to beta blockers, but usually much more powerful. They really pump the brakes.
And then things get weird with the miscellaneous or class V agents. Adenosine and digoxin, they do something totally different.
They cause hyperpolarization.
Meaning they make the cell even more negative.
So negative that it takes way longer for that slow drift to ever reach the firing threshold. It dramatically slows things down.
Let's talk about digoxin. It's unique. It helps with rate and with the strength of contraction.
It's got two great benefits. For rate control, it stimulates the vagus nerve, which releases acetylcholine, and that whole cascade ends with potassium channels opening. Potassium rushes out, hyperpolarizing the cell.
So that's how it slows the heart. What about the second part, the positive inotropy?
That happens in the muscle cells. It inhibits a pump, the Na plus K plus ATPase. So sodium builds up inside the cell, and that messes up another exchanger, which ultimately leads to more calcium inside the cell.
And more calcium means a stronger squeeze.
A stronger contraction, which is why it's so great for patients who have both atrial fibrillation and heart failure with a reduced ejection fraction.
What about edisine? That's not a long-term drug.
No, it's the emergency firefighter. It activates a receptor that causes a massive but very short-lived rush of potassium out of the cell.
How short-lived?
Seconds, which makes it useless for something chronic like AFib, but perfect for slamming the brakes on a reentrant SVT. It's like a chemical defibrillator for the AV node. It hits the system and then it's gone.
Okay, that's our rate control toolbox.
Yeah.
Now let's switch gears completely. Strategy 2, rhythm control.
Right. The goal is no longer just slowing things down. We're trying to suppress the abnormal firing in the myocyte tissue itself. We want to restore a normal sinus rhythm.
So now we're targeting the fast-action potential tissue.
And this is where we bring out the scalpels that target the sodium and potassium channels in the atrial and ventricular muscle.
Starting with class 1, the sodium channel blockers. They all work by slowing down that super fast phase 0 upstroke. And they're classified by strength, right? The mnemonic CAP.
C is for class 1C. Flecainide, propafenone. These are the strongest sodium channel blockers. They cause the most dramatic decrease in that phase 0 slope.
But here's the crucial and frankly terrifying clinical detail. They have basically no effect on how long the action potential lasts.
None. They don't prolong the refractory period, and this is the high-stakes trade-off. Because they're so good at slowing conduction, if you give them to a heart that's already a bit damaged or ischemic,
You can actually create new short circuits.
you can create new deadly reentrant circuits. And without that protective prolonged refractory period, it's a recipe for ventricular fibrillation.
So the warning here is absolute. If a patient has structural heart disease, coronary artery disease, LVH post-MI, you just do not use these drugs.
It cannot be said enough. The risk of sudden cardiac death is too high. These are for structurally normal hearts only.
All right, moving to the middle group, class 1A, procainamide, quinidine. Moderate sodium blockers, but they have a twist.
The twist is that they also have a weak potassium channel blocking effect. So they slow down phase 0, but they also slow down repolarization.
Which means they increase the action potential duration, they prolong the QT interval.
Exactly. And that puts you at risk for a specific deadly arrhythmia called torsades de pointe.
Okay, now for the weakest of the group, class 1B, lidocaine. And it does the opposite.
Right. This is so important. Lidocaine actually shortens the action potential duration.
Why would you want to shorten it? Isn't the whole point to make it longer?
Not always. Class 1B agents work best on ischemic, damaged tissue like you'd see after a heart attack. That damaged tissue is prone to abnormal firing. By speeding up the reset, by shortening the APD, you actually stamp out those pathological signals.
So that's why lidocaine is the go-to for treating VTACs right after an MI.
It's the perfect drug for that situation, which leads us perfectly into class 3, the potassium channel blockers, amiodarone, sotalol. These drugs are all about prolonging that duration.
Their whole strategy is to stop repolarization.
It's that simple. They block potassium from leaving the cell, so the cell stays positive for much, much longer. This massively increases the APD and the refractory period, which is great for stamping out reentry.
But just like class 1A, that prolonged repolarization comes with that same big warning.
It does. They all prolong the QT interval, which means they all carry a significant risk of causing torsades de pointe. You're using a drug to fix one rhythm, but you're running the risk of causing an even deadlier one.
This is where it gets real. Connecting these mechanisms to the high-stakes adverse drug reactions. These aren't just side effects.
No, these are direct consequences of the channel we decided to block, and they're often systemic. Take beta blockers.
We know they slow the heart, but they also block beta-2 receptors in the lungs.
which can cause bronchospasm in patients with asthma, and critically, they mask the signs of hypoglycemia. A diabetic patient on a beta blocker won't feel the tremors or the tachycardia of low blood sugar. That can be a crisis.
And calcium channel blockers. They cause constipation because they relax the smooth muscle in your gut.
Wow.
And you absolutely cannot give them to a patient in decompensated heart failure.
You can't. It'll make it worse. Then there's digoxin toxicity. This one is complex. Digoxin itself causes high potassium hyperkalemia. But the toxicity is made much, much worse if the patient has low potassium to begin with.
So low potassium makes the drug more toxic, which then can lead to fatal ventricular arrhythmias.
Exactly. Low potassium primes the pump, so to speak, for a toxic reaction.
And the Class I drugs have their own very specific strange side effects?
Oh, they do. Quinidine, a Class 1A drug, can cause synchronism headache, ringing in the ears, visual changes, and procainamide is famous for causing drug-induced lupus.
And we have to say it again for Class 1C. Proarrhythmic in anyone with a damaged heart.
It's the #1 rule. But the king of long-term complex side effects has to be amiodarone, the Class 3 drug.
Because it has iodine in it and an incredibly long half-life.
It sticks around forever. We love it because it's so effective, but we fear it because of its baggage. Long-term use can cause pulmonary fibrosis, liver toxicity, and it can wreck your thyroid, causing either hypo or hyperthyroidism. It's a huge commitment for the patient and the doctor.
Let's finish with the ultimate clinical puzzle here. Torsades de pointes. We know Class 1A and Class 3 drugs cause it. So how do we treat it?
Well, first you stop the drug that's causing it. That's step one. But what's so brilliant is how we use our knowledge of the action potential to treat it acutely.
It's so cool that lidocaine, a Class 1B drug, is a key treatment.
It's the perfect example of mechanism-based thinking. Torsades is caused by a pathologically long action potential. So what's the antidote? A drug that shortens the action potential. Lidocaine. You use it to pull the system back from that dangerous edge.
And beyond that.
Magnesium is the #1 treatment, even if we don't fully understand why it works so well. Or you can just increase the heart rate, either with a temporary pacemaker or a drug. By making the heart beat faster, you physiologically shorten the QT interval and close the window where torsades can happen.
So what does this all mean for you? We've laid out a map. Rate control is about blocking the AV nodes calcium channels, that's classes 2, 4, and V. Rhythm control is about suppressing the myocytes' sodium or potassium channels, classes 1 and 3. And choosing between them is all about the patient's underlying heart health.
Yeah, what really stands out is just how targeted these drugs are. When you think about that action potential graph, phase 0, phase 2, phase 4, you realize these aren't blunt instruments. They are molecular scalpels designed to alter one very specific part of the heart's electrical cycle.
We saw that both Class 1A and Class 3 drugs can cause torsades. This raises a critical question for you, the learner, that doctors face every single day. How do you weigh the risk of causing a new, potentially deadly rhythm against the benefit of fixing the one the patient already has? It forces you to treat the entire electrical system just as carefully as you treat the rhythm itself.